Hi friends, this is Dr. Ravi Kamapale. I'm an infectious disease, wound care, and obesity medicine doctor in LaGrange, Georgia, in southern Atlanta region. And we're going to be presenting on a poster at SAWC 2025 at Dallas. And this is one of the three posters that we're presenting there. And this is a retrospective review of moisture-related skin damage, which is a huge problem, and a tactical approach with close monitoring that we had followed, and over time come up with a process that has helped our patients. We are located in Georgia, and our website nobadbugs.com, and hashtag we use is removing barriers to healing, and X handle is wound physician. We'll go through the abstract quickly. This is a common problem that we see in healthcare with the de-cubitus ulcer that the people that are being taken care of in healthcare with significant problems with incontinence in these people who are immobile and mostly laying in the bed, and having problems with moisture that is related from feces, urine, and perspiration, and also problems with continued heat and moisture in this sacral coccyx region and intergluteal fold that is leading to a significant problem. Here we used a process where we used antimicrobial gauze, calmoseptine peri-ulcer protection, which is zinc oxide cream, and also used a no-sting cyanoacrylate cream and consistent supervision, and showed that we had a significant improvement in the healing, approximately in a lot of significant changes noted with this ulcer bed being evaluated with stable, improving, resolved, and healed areas. And also the whole process of improvement also showed significant changes that are needed to be closely monitored with this care delivery. And this is a multifaceted approach, and we need to make sure that we follow this process closely. And in this process, we used a classification of global intertriginous dermatitis expert panel, but it's called GlobeAid process for MASD. And mostly MASD is being under-recognized or misclassified as the origin of the problem could be MASD, but the patient could end up being diagnosed as de-cubitus ulcer. So it kind of progresses into that state. So we need to develop individualized protocols and process for each patient. So here we went through a retrospective review of 185 patients who had moisture-related skin damage, and these inclusion criteria was the diagnosis established and also standardized wound care plan that was followed. But in the retrospective review, we use a GlobeAid expert panel staging system to retrospectively review the pictures that were taken on all these patients. And we followed a standardized methodology where we used AMD gauze and basically antimicrobial, it has antimicrobial effect, and use peri-ulcer protection with calmoseptine or no-sting cyanoacrylate. And we use a skin separation method where we, if there is an intergluteal fold that is together, we flush the antimicrobial gauze placed in between the intergluteal fold and contoured the tape to be around the intergluteal fold, not bringing it together, but contouring the tape to follow that with the taping, Medipo tape, or supportive interventions involved regular examination, hygiene management, and moisture control. This was explicitly educated with the same staff being educated again and again. And over time, we also looked at how these ulcers improved with these healing, resolved, improving, deteriorating, or worsening criteria that we established on review of the pictures. And data was compared with this GlobeAid scale along with issues were looked at with the comorbid conditions. So quickly to go through this GlobeAid tool, it was developed at Ghent University in UK. And this involved a 2-year research project involving 22 international experts with 832 clinicians involved in 30 countries. And basically, it was for incontinence-associated dermatitis. And this involves looking at first criteria, looking at redness, and the second criteria being skin loss with infection. So basically, redness with infection, redness when there is only redness without sign of infection is 1A. Redness with clinical sign of infection is 1B. When there is skin loss, though, then if there is no infection or infection. So that is the 2B with infection. So basically, we use this criteria to go back and continually assess the pictures of all the pictures over time which we have sequentially collected on all the patients that were reviewed with the diagnosis of MASD. In these patients, we can, as you can see, the whole, when compared to the whole, all the criteria data, there had been a significant improvement in 54.9 patients with 20% being stable, 15% being healed, and worsening of 9.44%. And basically, if you see, most of them appear to be the 2A category. And if you see that, we'll go through this different category at the next slides. But if you see here, we also looked at all these patients having a de-cubitus ulcer staging also included, which in these patients that we have, what we noticed is that we cannot stage back on improvement. So we looked at how they improved, healed, or worsened. If they were stage 1, they improved remarkably. If they are here, basically the whole process of final staging is hard to determine because we cannot go back in the staging. So either way, what we notice also is that the comorbid conditions did not have a significant impact that was noted in this study. So here, I just want to go through this one quick case of an 80-year-old male who was found in the acute care hospital with diarrhea after he fell down, had rhabdomyolysis with hydronephrosis. He ended up having a Foley catheter replacement with Foley that was removed, and ended up getting admitted to the facility there where the patient was for rehab. And it was in October 2023. He had significant problem that was noted with the skin breakdown, with moisture, with urinary incontinence that was noted, and also sacrococcyx breakdown. And essentially, within a few days, with the ulcers showed up, from October 5th to October 9th. And basically, Foley was off, and so it had to be replaced. And he was noted to have purulent urine, and we started IV antibiotic therapy and active local wound care. And he was discharged with a continued approach to this care plan. And essentially, if we can notice here, he went on to have this problem with skin breakdown, with the moisture-related skin breakdown. So the ulcer continued to worsen. So a sequential debridement of the de-cubitus ulcer now, which has applied as no sting and acolyte around, and protect the peri-wound area. And essentially, once he got discharged, he ended up having the active local care with AMD gauze application and intergluteal fold separation. So normally it is thought that if you put a fluff gauze inside in this intergluteal fold that is bringing it together, we are undoing the pressure. So I do think that clinically what we have noticed in what we have been doing is when we undo the pressure, which intergluteal fold pressure in the cleft, I think that is the best approach to improve this outcome, because the pressure should reduce, but that is my clinical experience. But pressure monitoring approaches have to be intervened, or that study has to be done. So in this discussion, as you can see here, in patients who have these problems with category 1A, that is a patient with redness without signs of infection, there was a significant improvement. And with the category 1B, with which persistent signs of clinical infection, but no skin breakdown, the patient had improvement in 57%. And a category 2A with skin loss without clinical sign of infection, there was 12% healed, but 56% improvement. And category 2B, and we did not have much healing criteria by the criteria that we followed, and it showed improvement of 44%. And 11% worsened, and for the stable 4 was 44. But either way, what it just comes down to is for anyone to understand that this global aid criteria is something that has to be looked at, and also trying to look at understanding how this identification of MASD has to be addressed and closely evaluated. And in conclusion, this is a retrospective study of 185 patients with MASD with clinical significance of being early detection in the intervention and personalized care that is needed. And majority of the patients had stage 2 to stage 3 ulcer with extensive skin breakdown, which we followed antimicrobial gauze, calmoseptine, no sting cyanoacrylate peri-ulcer protection, and also with successful facilitating healing of a lot of patients, more than 58%, and less than 20% went on to complete healing. It is a testament to the chronic nature of MASD, but also meticulous care that has been shown significant improvement. And we need to work on understanding the root cause, work on removal of the root cause, and using multimodality approaches, and also making sure that the staff training and guidance and close monitoring and tracking and hand-holding and personalizing a solution is very much needed for these kind of ulcers to prevent that from getting worse. So quickly, I want you to please look at the QR code for further understanding. I have before this 185 presentation, we did do a 50 chart review, and that was what prompted us to think more about this. And that was one of the that is there in the presentation there. And also we have a few video lists of a few cases, and also you can have the scan of the chart here. Thank you very much, and have a great day, and thank you for listening through the presentation. Thank you.